Good evening, ladies and gentlemen. Welcome to the SIG Clinical Aphasiology webinar on the dysphagia and with specific interest and focus on the dysphagia in Parkinson's disease. Today we have Ms. Rabab Rangwala, who is a student of Gayathri Hattiangadi ma'am, who is going to present about the dysphagia to all our audience. I hope this is going to be a wonderful clinical session for all of you. Definitely looking forward to have good interaction with each one of you, and we expect all of you to participate and interact for any kind of questions and make it more interactive session. I now welcome Dr. Krishna Vai. He is the president of Indian Speech and Hearing Association for to provide welcome remarks.
Yeah, good evening everybody, and welcome to this webinar, which is being the title of the topic being clinical assessment of dysphagia. Now there's a lot of things, especially in India, it's picking up. There's a lot of work going on in this area, and the current times of pandemic, I think the role of SLP is also an important one for us to understand. And when it comes to the neurological conditions, our role is even more important. And I'm happy to invite Rabab Rangwala from Northwestern University to share her experiences and knowledge on this topic with us. We will be starting the presentation, and later on Dr. Gayathri Hattiangadi ma'am also will join us in moderating this session, which we will be having it. And once again, I welcome all the participants for this webinar, and welcome Rabab. This you can start.
Yeah. Thank you, sir.
Thank you.
Today we have Mrs. Gayathri Hattiangadi ma'am as the moderator for the today's session.
So could I ask Joint Secretary Sonal, please welcome Miss Rabab, as ma'am is still trying to join, and she can take up the moderation once she joins back with the audio setting.
Yeah, before that I'll just introduce Gayathri ma'am also once.
Yeah, sure.
Mrs. Gayathri Hattiangadi ma'am, currently she is working as HOD of Topiwala Nair Hospital, ASLP department, and she is one of the pioneering SLP in the field of swallowing rehabilitation in India. Her interest includes dysphagia, neurogenic communication disorders, and advances in swallowing rehabilitation. She is also an author of Nair Hospital Bedside Dysphagia Tool, and she is a down-to-earth, humble, knowledgeable person, and who is also an active member of ISHA and also leading founder member of Indian Federation of Neuro Rehabilitation. She has been mentoring many of the students in speech language pathology for swallowing and neurogenic communication disorders. We thank you, Dr. Gayathri Hattiangadi ma'am, for joining us as a moderator for the today's session. And yeah, to introduce the speaker, today we have our own speech language pathology pathologist who have completed her bachelor's from Topiwala Nair Hospital in Mumbai, and subsequently she had completed her MS in speech language pathology, and she is also a certified speech language pathology of ISHA, and currently she is doing her PhD at Northwestern University in the United States of America, and her areas of interest include dysphagia and clinical assessment and management. Dear Rabab Rangwala, we thank you for providing your consent, and thank you for sharing your knowledge. We request you to start your presentation.
Thank you so much. Happy Saturday, everybody. Thank you so much for joining us, and thank you for that introduction. I am excited to be here and it's an honor. While we discuss dysphagia, its presentation, evaluation, and treatment in individuals with Parkinson's disease. My friends joke that I'm obsessed with dysphagia, and as a new therapist and a current PhD student starting my journey of dysphagia, I promise my best to provide you with the knowledge and the information I possess today. These are some disclosures. I do not receive any financial compensation from ISHA or any other organization. I do not have any conflicting interests with the materials presented during this talk. I am the host of a podcast named Made in India SLP, but do not have any conflicting interests there as well. And I do not provide consent to anybody else except ISHA to record or publish this presentation. This is a little bit about what we'll be talking today, just a brief outline of contents and topics that I'm hoping we can explore today. Our first subsection involves a review of dysphagia and our swallowing system and its functioning. I thought we would start with a brief overview of our swallowing anatomy that I know that we are all familiar with, but understanding the anatomy of swallowing is fundamental to evaluating and treating disorders of eating and swallowing, as well as developing dysphagia rehab programs. So I don't think you can see my mouse, but our oral cavity begins at our lips and an opening through which we accept any kind of PO intake. The tongue has both oral and pharyngeal surfaces, and the oral cavity consists of our tongue and our teeth. Our oral cavity is separated from the pharynx by fascial pillars. The pharynx is further divided into the nasopharynx, oropharynx, and hypopharynx. It has a layer of muscles that originate from the cranium and hyoid bone, and they insert anteriorly, and the cricopharyngeus muscle is attached to the sides of the cricoid cartilage anteriorly and closes the upper esophageal sphincter that we commonly know as the UES. The larynx is situated anteriorly, which is in front of the pharynx, and the space between the pharyngeal surface of the tongue and the epiglottis is called the valleculi. The epiglottis originates in the larynx and is angled upward and backward. These are the phases of swallowing. The physiology of swallowing is usually divided into 4 different phases. These phases work cohesively and dynamically to ensure efficient transfer of food from the oral cavity to the stomach. So let's talk about the first phase, which is the oral preparatory phase. Well, this is a webinar in India, so I thought it would be appropriate for us to discuss something like eating my favorite dish, pani puri. So our oral preparatory phase would begin with anticipation of a bite of pani puri into our oral cavity. When the piece of food is brought to our mouth, it is bitten off and then chewed or masticated further in the oral cavity, just right here. The tongue seals the bolus, which is the masticated food, towards the hard palate, and it leads to mashing of food against it. The saliva plays an important role in formation of the bolus. It moistens the food, assists in bolus preparation, and helps build an organized bolus in our mouth. In a similar way, liquids are sipped by our lips into the oral cavity and prepped to form a bolus. If there is any kind of deficit in the oral preparatory phase, it would likely result in bolus loss or escape, which is food coming out of the mouth, disorganized or slow mastication, and bolus loss due to inability of the tongue to maintain palatal seal, or the tongue cannot move the food towards the back of the throat. Our next phase is the oral transit phase. Now, once the bolus is prepared, the oral transit phase is initiated by the posterior movement, which is the backward movement of the bolus. The tongue sides and its tip get anchored to the alveolar ridge, and the bolus placed anteriorly in the oral cavity is moved posteriorly by movement of the tongue, squeezing and rolling it against the hard palate. This phase lasts for somewhat about 1 to 1.5 seconds, and at the end of this phase, the pharyngeal phase is triggered, which is the next phase of swallowing. Any deficits in this phase of swallowing, which is the oral transit phase, can lead to a delay in the pharyngeal swallow or presence of bolus or residue in the valleculi. The next phase of swallow is the pharyngeal phase. When the bolus passes the area around the base of the tongue, the pharyngeal swallow is initiated. In this phase, a series of motions occur simultaneously. The velopharyngeal, which is the VP port, closes and contains the nasal cavity, so it becomes somewhat like a closed room so that the food cannot go upward into the nasal cavity. The larynx moves forward and upward while the epiglottis inverts so that the food can go towards the stomach in the esophagus. Once the epiglottis inverts, no food can go in the airway. The tongue base touches the posterior pharyngeal wall, delivering the bolus to the pharynx. The pharyngeal constrictor muscles contract in a top to bottom sequence, allowing the bolus to pass posteriorly down the pharynx. When the pharyngeal phase of swallow is negatively impacted, common deficits noted may be incomplete closure of the VP port, inadequate hyoid or laryngeal elevation, or epiglottic inversion, or an inefficient pharyngeal stripping wave. Now comes the esophageal phase. When the bolus reaches the cricopharyngeal muscle, the esophageal phase is detected. Esophageal propulsion begins with muscle contractions initially when the bolus is detected. When the bolus enters the esophagus, the combined forces of peristalsis and gravity carry the bolus downward. Deficits in the esophageal phase may lead to incomplete transfer or presence of residue in transfer of the bolus between the pharynx and the stomach. These deficits, I think it's important for me to mention, are diagnosed by a radiologist or a gastroenterologist. SLPs do not diagnose esophageal disorders. So in conclusion, there are 4 phases of swallowing which are mutually codependent and lead to an efficient transfer of bolus through the oral, pharyngeal, and esophageal cavity. Now comes to the topic of our day, dysphagia. Dysphagia is defined as problems involving the oral cavity, pharynx, esophagus, and gastroesophageal junction, which is also commonly known as a swallowing disorder. So this brings me into a question: who helps individuals who have dysphagia or swallowing disorders? And I'm hoping you guessed right. It's us, the speech language pathologists. Now, speech language pathologists with appropriate training and competence are involved in the diagnosis and management of oral and pharyngeal dysphagia. We are integral members of an interprofessional team that addresses any swallowing disorders. Before I go ahead, I'd like everyone to take a few seconds and think about few roles of SLPs in dysphagia evaluation and management. Okay, so I'm hoping that everyone has some answers in their mind, and here is a non-comprehensive list of our roles and responsibilities. It involves identification of dysphagia, providing safe and effective treatment, collaborating with radiologists, physicians, ENTs, performing non-instrumental tests like the bedside swallow examination, being aware of age-related swallowing changes known as presbyphagia, making diagnosis of dysphagia, which is a diagnosis that is within our realm and something that we do make, performing instrumental tests like the MBSS, providing education, counseling, and most importantly, advocating for our patients. There are many other things we do. Just to briefly say some more, practicing collaboration with other medical professionals, educating other professionals as well about swallowing disorders, performing, analyzing, integrating information from swallowing studies, and helping our patient to the best of our abilities. So now it's time to brainstorm. What are some conditions, disorders, diseases that can lead to dysphagia? To make this more interactive, just think of some causes of dysphagia before we move forward. If you could list them based on oral, pharyngeal, esophageal, that would be very great. So, dysphagia can occur due to damage to the central or peripheral nervous system in our body. As correctly guessed by many of you, here are some causes of dysphagia. It can be stroke, traumatic brain injury, dementia, Parkinson's disease, and developmental disabilities, head and neck disorders. These diseases that I've listed make up the majority of the caseload of an SLP evaluating and managing dysphagia. Some other disorders and causes of dysphagia can also be multiple sclerosis, ALS, muscular dystrophy, myasthenia gravis, cancer in the oral cavity, pharynx, esophagus, any kind of oral intubation or tracheostomy, and I can go on, but unfortunately we don't have so much time. Our next subsection focuses on the clinical swallow examination, which is also known as the CSE. The clinical swallow examination, or the clinical bedside swallowing evaluation, is a component of the dysphagia diagnostic process. That process has 3 steps, which includes case history, patient interview or observation, bedside swallowing evaluation, which is the subjective swallowing evaluation, and if needed, the instrumental evaluation is the final step of the CSE. Case history. Case history is the first and a very important step of the CSE. In my mind, I think about it as our first interaction with the patient without actually meeting them in person. It helps us learn more about their disorders, diseases, and history. So these are a list of things that we can get from a chart review. I, for one, spend at least 10 to 15 minutes reviewing the case history before meeting any patient. Once I know more about the case, I'm able to predict how the session with them will look, and I'm prepared for appropriate questions as well. So I think this is something that should be the first step for any clinician doing a dysphagia evaluation. The medical history gives us information related to chief complaints, reasons for admission to the facility, or any other important comorbidities. So I would like to share one of my goof ups as a young clinician. I'm hoping this will help others, just as an example of what you should not do. I was preparing to enter a patient room without the chart review done already, which was my mistake number 1. Secondly, I did not speak to the nurse prior to entering the room, which was mistake number 2. And fortunately, when I went to enter the room, the nurse was already there and she was covered in PPE. The patient had a communicable disease, and had I entered the room without PPE or adequate precautions, I would have put myself at risk. So right now, especially during COVID times, I think this is a very important example about how medical or surgical history is of utmost importance to protect ourselves and our patients. So make sure you're looking, reading what is the medical record saying, getting information from other medical staff. Nurses are my best friends and they give us so much information. So that is something you should definitely listen to. As a dysphagia evaluating therapist, having knowledge of prior level of functioning related to diet consumption is absolutely necessary. Is the patient on a pureed or a regular diet? Do they require mild feeding assistance or MAX? Our dietary notes will provide all this information. Let's remember we are there to help their swallowing disorders. By providing any wrong PO intake, we might cause a swallowing disorder and we do not want to be liable for that. So look at the current diet recommendations. What are they eating currently? What solids, what liquids are they NPO? Are there any alternative nutrition methods like an NG tube or gastrostomy, total parental nutrition? How is their feeding method? Are they independent in feeding or do they need some assistance or are they completely dependent? All of this will help you before you do a bedside evaluation. Respiratory and mental status review will help us predict how our session might look. If a patient is agitated, it might not be the best time to do a swallowing evaluation unless you want to be the brunt of that anger, which I usually don't. If they're having poor respiratory status and require oxygen continuously, it would be a smart move to check with the nurse before beginning any PO intake. We do not want to compromise their respiratory status. So check their endurance during meals. Is it good, fair, poor, variable? Is their mental status alert, responsive? Are they cooperative or confused? Remember that with dysphagia, there come many comorbidities, and let's say they had a traumatic brain injury, which usually leads to impulsivity or combativeness. It would be a smart move after checking everything to like wait to do a swallowing evaluation. Then comes the patient interview and observation. A mentor of mine once told me, listen to the patient because he or she knows their body the best, which I think is absolutely right, isn't it? So listen to the patient. Ask about their chief complaints, what made them seek medical advice, learn about their relationship or their interaction with food intake. How long does it take them to eat? Is there pain? Do they require help? If the patient is unable to share their difficulties, learning more from a caregiver is very important. You can ask questions like, how frequently does the swallowing problem occur? And is there a consistency that's more problematic? Can you have any kind of, let's say, khichdi or soft rice or idli easily, but is, let's say, having something more hard like puri or a biscuit or like a parle-ji more difficult? Something I have seen that patients relate to is like the parle-ji. When you put it in like chai or like milk, is it easier to eat? Which many people you'll see do it very subconsciously. Is there any adynophagia, which is pain while swallowing? Is there congestion? Has your voice changed? Is there weight loss? So just questions you can ask. The more you talk with them, the more you listen, the more information you get. And another important question before I go ahead is to ask about history of aspiration or pneumonia. Chances are if they've been hospitalized for pneumonia before, that should get some red lights, red bulbs shining in your brain about, okay, the chances of having dysphagia are much higher. Now, cognition and communication abilities. An effective swallowing evaluation cannot be done without a cognitive communicative evaluation prior to PO intake. Let's imagine a patient requires a compensatory strategy of a chin tuck. If we do not know if he or she can follow one-step commands effectively and we provide PO intake, it can have an aspiration or penetration risk. Let's say if a patient has a voice disorder, It will make us aware that during informal assessment of voice change during PO intake, that might not really work, right? It might not be the most effective subjective evaluation strategy. So awareness is key. Make sure you're informally checking any kind of ability to express needs, their memory abilities, and their abilities to follow 1 and 2-step directions. Now, let's talk about the oromotor evaluation. The oral mechanism examination and the cranial nerve examination is a very important step in any evaluation of swallowing. This might be a funny analogy, but every time I think about it, I think about a car. If it does not function adequately or has a missing structure, the overall abilities are negatively impacted. So let's say if a car does not have a wheel or it is low on petrol, we can't expect it to drive us to our destination with no problems. That's not going to happen. So just like that, the oromotor examination gives us information about the oral anatomy and physiology. If I do an examination and let's say I see a left-sided facial droop, in my mind, I'm actively thinking about the right-sided cerebral hemisphere involvement. If I see a decrease in diadokinetic rates, which is or PTK, I'm thinking about change in the rate of movements. So things to assess, look for a volitional cough, look for vocal quality, and especially oral hygiene and dentition is something that you should consider as well. These are some slides that I got from the American Speech and Hearing Association website, and it's something that I use in my clinical life to do an oromotor examination. So the first one is an objective examination, which has the oral status, looking at the dentition abilities. The second slide looks at oral motor, respiration, and phonation. So the lips movement, the tongue movement, the jaw, the soft palate, looking at its functioning, its anatomy, and physiology. The third page looks at voice quality, respiratory sufficiency and coordination. And then lastly, it comes to food and liquid trials and saliva swallows. This is available on the ISHA website, and I would encourage you to go look at it. Now comes to one of the main steps of a dysphagia evaluation, which is bedside trials. The bedside PO trials provide invaluable information related to a patient's swallowing abilities. As a clinician, it gives us a very good chance to subjectively evaluate abilities when provided different solids and liquid consistencies. We look out for signs and symptoms of aspiration or penetration, like a wet voice or a cough. We look at the rate of acceptance of food. How are they chewing? Do they require any specialized equipment like a straw for easier PO intake? Just looking at different permutations and combinations of how to decrease signs and symptoms of aspiration or penetration during PO intake. Here is a protocol that I've again downloaded from the ISHA website. These are the solid food trials organized by the food item, administered by amount, response, strategies, and swallowing duration. Here's a small example I've created. Let's hope it works. Yes. So let's say the first food item is soft fruit, which would be a mechanically soft solid. How's it administered? It's administered by a spoon. I gave 1 teaspoon of soft fruit. Was there a spontaneous cough? Yes, so I would tick yes there just so that I know. Did I use any strategies? Yes, I used a chin tuck. And then I would write about the swallowing duration. So just like this, I really like this because it gives you a format and a protocol to improve standardization even during subjective trials. The same protocol exists for liquid trials, where you would go through thin liquids, nectar thick liquids, honey thick, and pudding thick. And you would do the same thing, check about how it was administered, amounts, response, and strategies. Here is the Mann Assessment of Swallowing Ability, also known as the MASA. It is a subjective evaluation test that I like to utilize during bedside trials. It is a perfect mix, and it incorporates oromotor evaluation and results during a bedside swallowing trial to give us a very conclusive diagnosis. I will warn you that this test is subjective, but it is widely utilized, and you can find a PDF online for free. So when a CSE concludes, when we do the patient interview, we do the case history, we do the bedside swallowing, our question is, why are we doing all this testing? So our final goal is to have a diagnosis of presence of dysphagia. Is dysphagia present or not? What is its type and severity? Okay, now if we know dysphagia is present, what do we do next? What are our recommendations? So an example of this would be looking at the second point, the oral stage. I would say from my findings of the CSE, I would conclude this is just an example, unilateral weakness or decreased sensation from the OME, which is the oromotor examination. There was labial leakage, or there was residue, there was pocketing, or efficiency of mastication was reduced. So those are conclusions I would get regarding the oral phase. For the pharyngeal phase, I can say there was a cough, there was throat clearing, vocal quality changes, but do remember that we cannot see if there's aspiration or penetration in the pharyngeal stage. My final findings would say, okay, swallowing is within normal limits, or there's a swallowing diagnosis. It's an unspecified dysphagia, or it's an oral phase dysphagia, an oral pharyngeal phase, or only a pharyngeal phase. The severity was mild or mild and moderate, moderate and severe. So that is the reason we do a CSE, so that we can reach that conclusion. Now, somebody asked me the other day that what is the one superpower you had as a clinician? And without even thinking, I said, I wish I had X-ray vision. Don't we all wish that was true? But unfortunately not, which is why instrumental studies should be our best friends. One of the studies is the video fluoroscopic swallowing study, or the modified barium swallow study, which is the MBSS, which is a radiographic procedure which provides a direct dynamic view of our oral structures, our oral pharyngeal and esophageal functioning. I think I will be the first one to say this, that the CSE has many limitations. There is a subjective bias, there are a lot of subjective components. Detecting aspiration utilizing the CSE is less than 70% accurate. Anything beyond the oral phase, which is our mouth, our tongue, our lips, we cannot see it. And most importantly, we cannot judge for silent aspiration. So this is where the instrumental swallowing study comes into place. We have to advocate for instrumental studies in India and for our patients as well. However, I do understand that clinicians have limited access to resources, which is why it is our responsibility to learn to use the CSE as effectively and as objectively as we can. If we use a particular protocol that best suits our patients, and performing it as a wholesome test will help us reach a correct diagnosis. So here is the MBSS, which is the gold standard for instrumental studies. I am going to show you a quick video. Let's see. Oh, it's working. Okay. So here is the MBSS. This is a normal swallow, where the food enters the esophagus and not the trachea. goes down very smoothly. In the second one, it is an abnormal swallow. You see how it's pooling, and then you see aspiration where the food's entering the trachea. That's a very clear aspiration instead of the esophagus. Okay. Now it comes to the next instrumental evaluation, which is the FEES, which is the fiber optic endoscopic evaluation of swallowing. With the use of a small flexible telescope, we are able to visualize areas surrounding the voice box and the esophagus. Here is a small video of the FEES examination. I am going to skip through it a little.
And we give you different, just a little bit past that white line. There's not much space between your nose and your throat, so it doesn't have to go in very far. We're not in there very long, just long enough to take a look around at the anatomy, give you a couple of things to eat and drink, watch you swallow those, and then we come out. Okay? So the different items we're going to be swallowing, we like to do an assortment of consistencies, so we do.
Can you see? If you want, we can show you afterwards. Yeah.
Okay, so this is the FEES. Now, why do we recommend and advocate for instrumental studies? Of course, as we know, it can complement every clinical swallow study with an instrumental study, and that would happen in the most perfect ideal world. But in some cases, like when you're concerned about the safety and efficiency of swallowing, when you have to identify a disordered swallowing physiology, or there are inconsistent signs and symptoms, so you're not really sure what's happening. If you need to make a differential medical diagnosis, if there's presence of a medical condition or diagnosis with a high risk of dysphagia, if there's a previously identified dysphagia or presence of a chronic degenerative condition, these are all indications that it is essential to get an instrumental swallow evaluation done. What are some contraindications? Let's say the patient's not medically stable. He cannot participate in an instrumental examination if he's combative or agitated. Or the SLP's clinical judgment indicates that any kind of MDS as a FEES won't change the clinical management. So I did a clinical swallow study, and I think that I'm absolutely correct that there's oral dysphagia. There is difficulty in mastication, so doing an MBSS doesn't really help me or make me change my recommendation. Due to time constraints, I will not go deep into dysphagia rehabilitation, because if I do, we all will be stuck here till 12 in the night, and I'm sure nobody wants that. So I thought I'll quickly discuss a few points. There are two options in any rehabilitation process: intrinsic and extrinsic. Rehabilitation focuses on strengthening of oropharyngeal musculature, whereas compensatory strategies focus on things that you can change externally. So like positioning, make sure you're sitting at 90 degrees at all times while eating. Maneuvers like the chin tuck, effortful swallow, supraglottic swallow, or any dietary modifications, like making sure there's only pureed and nectar thick food and liquids, making sure that any kind of changes to diet will help decrease the risk of dysphagia. Here is the International Dysphagia Diet Standardization Initiative, which is the IDSI. The IDSI framework consists of a continuum of 8 levels, which goes from 0 to 7, where drinks are measured from levels 0 to 4. And as you can see in the scale, it starts from thin, slightly thick, mildly thick, moderately thick, and extremely thick. While foods are measured from level 3 to 7. So 3 would be liquidized, 4 would be puree. Puree would be like yogurt, dahi. 5 would be minced and moist. 6 would be soft and bite-sized, like let's say soft food, mosambi, oranges. 7 would be regular or easy to chew. The ISHA framework provides a common terminology to describe food textures and drink thickness. Using this framework helps in standardization of diet modifications. So let's say you see a patient in Delhi and then you see a patient in Bangalore. If we are all using the ISHA framework and the patient tends to travel and see another therapist, we exactly know what the other therapist was thinking without really having to talk to her. I thought it would be fun and interesting for us to do a small case study just to test our knowledge, see our understanding. So there's a 65-year-old man post-stroke admitted with a diagnosis of right side paresis and requires a dysphagia evaluation. So in my mind, I'm thinking, okay, so he has right side paresis, right side is the weaker side, the left side is the stronger side. Also, something to think about here is the right side paresis is usually due to left cerebral damage. So, and as we know, any kind of left cerebral damage can cause an aphasia. Of course, it's not always necessary, but chances are there. So make sure you do a cognitive and communicative evaluation just to see how his expression and reception is. So the next thing we do is tests. We do the CSE comprising of case study, patient interview, bedside trials, and oromotor evaluation. I'm seeing that the right side there's a droop. He's using the left side to masticate more than the right. And other than that, it looks pretty fine. I would see there's a moderate to severe right-sided oral paresis. Would you expect any kind of dysarthria? Yes. If there's such a severe paresis, chances are I would expect one. I do bedside trials. There's coughing noted on thin liquids 2 out of 3 times with a decrease in oxygen saturation levels. There's difficulty in mastication of regular solids. So let's say I give him a piece of Parle-G or any hard biscuit, and there is max to moderate oral residue on the right side of the oral cavity. There are no other signs or symptoms. So I'll give you a few seconds to think about recommendations and diagnosis. I would diagnose it as a oropharyngeal dysphagia post-stroke because it says he had a post-stroke oropharyngeal because there is coughing and there's difficulty in mastication. What would be my recommendation? I would maybe recommend a nectar thin liquid diet, nectar thick liquid diet, and maybe mechanical soft solids so that it's easier to chew. I would recommend an instrumental evaluation because, as we said, in the pharyngeal area, I cannot see what's happening. I do not have X-ray vision. And there was coughing noted on thin liquids. So there is a risk of aspiration and penetration. And I want to see what happens next. Now comes to the highlight of our topic of the day, which is Parkinson's disease and its pathophysiology. Now that we've discussed the anatomy and physiology of swallowing, as well as of the motor system in our bodies, let's talk about Parkinson's disease. PD is a neurodegenerative progressive neurological disorder, which is caused due to loss of neurons in the substantia nigra of the basal ganglia. The history of Parkinson's disease, just a fun fact, expands from 1817 when James Parkinson published an essay on the shaking palsy to modern times. The term Parkinson's disease was coined in 1865 by William Sanders and later popularized by French neurologist Charcot. You probably don't need to know that as a speech language pathologist, but I think it's nice to know. I'm going to show you a short video.
Yeah. Well, I mean, it's happy-go-lucky as I seem to be, and as it is as with this as I seem to be. I mean,
this is Michael J. Fox. He's a famous individual with Parkinson's disease. And here's a clip I thought would be interesting for us to see, just to see how Parkinson's disease and its manifestations look.
Yeah.
Oh, sorry.
Well,
This is a video, a picture of the symptoms and certain characteristics of Parkinson's disease. As you see, there's something known as bradykinesia, which is slow movement. Rigidity, which is stiffness, inflexibility of the limbs, neck or trunk. It's rigid to move. Tremor, something that is the most outward symptom or sign that we see, which is the involuntary shaking that decreases with purposeful movement. So let's say my hands on the table, and somebody with Parkinson's disease, an individual with Parkinson's disease, his hand's on the table and his hand will keep on moving. If he moves his hand to go pick up a glass, it decreases, the tremors decrease. So that's something that physicians and neurologists use to diagnose Parkinson's disease. Tremors typically start on one side of the body and it typically starts on the hand. You'll see that they have a masked face, which is known as hypomimia, which results from combination of bradykinesia and rigidity. So it's just like a rigid face, no expressions, no smiling, no laughing, no sadness. It just looks very masked. They have cramping, which is known as dystonia, which has sustained or repetitive twisting or tightening of muscle. So as you see in the Michael J. Fox video, he keeps on twisting, there's tightening of muscle, it's very repetitive. And most importantly for SLPs, they have hypokinetic dysarthria. It is a motor speech disorder distinguished, distinguished by low intensity of voice or speech. So if I'm in my clinic and I'm seeing a patient with a motor speech disorder, and one of the characteristics is low intensity of voice, I should 100% think about hypokinetic dysarthria. Bradykinesia, which is slow movement, plus either tremor or rigidity, must be present for a Parkinson's disease diagnosis to be considered by a neurologist. Oh. Okay, so another symptom to keep in mind is that individuals, and if there's anything you take away from today's presentation, take away this, that individuals with Parkinson's disease suffer from slow or less movement. Let's say it together. Less, which is hypo, less movement, and slow movement. This should not be equated by the presence of weakness. So let's say if I give a patient with Parkinson's disease a stress ball, like those yellow balls to squeeze, his muscles can contract with adequate strength. The movement might be slow, or it might be delayed in initiation, but the strength of the movement is not negatively impacted by Parkinson's disease. So I will say it again. And because when I learned about this, it was something that surprised me. So I want to share it with you. Slow and less movement, not weakness. Individuals with Parkinson's disease present with rigidity, and this leads to the decreased movement. So in individuals with neurological disorders like stroke, the motor neurons degenerate. Traditional swallowing therapy that we provide to patients with strokes or ALS focuses on strengthening. So you do oromotor exercises like, okay, stick out your tongue 10 times a day to the left and the right, your strength training. However, this is not true in the case of Parkinson's disease. And any kind of therapy exercise to enhance strength of musculature is not indicated. I will say it again, therapy targeting strength training is not indicated. So how is the progression of dysphagia in individuals with PD? Something to remember is that it is not consistent. Swallowing deficits can be an early sign noted for some individuals and a late symptom noted in others. The progression of dysphagia, it is not proportional to presence of motor symptoms. An individual with severe tremors or rigidity, will he necessarily have difficulty swallowing? No. On the other hand, sometimes dysphagia is the first symptom or an early symptom that patient presents with during an evaluation with a speech-language pathologist. So it is our duty as SLPs to recognize possible signs, symptoms of dysphagia and Parkinson's disease, and to make appropriate referrals to a neurologist as indicated. Something I would like to talk about is the substantia nigra. The substantia nigra is a basal ganglia structure which is located in the midbrain. It is divided into the substantia nigra pars reticulata and the substantia nigra pars compacta. The pars compacta serves mainly as an output to the basal ganglia circuit, which supplies the striatum with dopamine. Remember the hormone dopamine. Parkinson's disease is characterized in part by the death of dopaminergic neurons in the substantia nigra pars compacta. So death of the neurons that give dopamine. What is the cause for this death? It is unknown. It is interesting to note that regardless of the cause of neuronal death, the plasticity of the pars compacta is very robust. So tremors, rigidity, bradykinesia, symptoms like that of Parkinson's do not appear until 50 to 80% of the pars compacta neurons have died. Dopamine is a hormone and a neurotransmitter, which is an organic chemical of the catechol-amine and the phenethylamine families. It plays several important roles in the brain and the body. Inside the brain, dopamine plays important roles in executive functioning, in motor control, motivation, arousal, reinforcement, as well as reward. The anticipation of rewards increases the amount of dopamine in the brain. So let's say I know that if once I finish this presentation, I have a nice piece of chocolate cake waiting for me. So that increases the amount of dopamine in my brain because it is the anticipation of a reward. As well as many addictive drugs increase dopamine release or block its reuptake into neurons following release. Dopamine producing nerve cells are very comparatively few in number. There is a total around 4 lakh in the human brain, and their cell bodies are confined to certain parts of the brain like the substantia nigra. However, these axons project many other brain areas and exert powerful effects on their targets. A loss of dopaminergic neurons, which in turn means a loss of dopamine in the substantia nigra, is a hallmark sign of Parkinson's disease. So as you see in this picture, in the upper portion, there are enough number of dopamine. The dopamine neurons is giving away enough amount of dopamine in the system, and in the second, which is a Parkinson's disease affected neuron, the amount of dopamine is greatly reduced. The incidence and prevalence of Parkinson's disease. It is present in 1% of people over the age of 65 years. Young onset Parkinson's disease, which means symptoms show up between 21 to 40 years of age, accounts for 3 to 5% of cases. Unfortunately, as of today, there's no homogeneous or large epidemiology data on Parkinson's disease in India. I did find one study done in AIMS, which shows there's a prevalence rate of about 14.1 per lakh in the population of rural Kashmir. There's a prevalence of rate of 27 per lakh reported from Bangalore, a prevalence of 16.1 per lakh from rural Bengal, and in the population of Parsis living in colonies in Mumbai, there's a prevalence of 328 per lakh. The study is again done by someone from AIMS, and it could be a nice resource to look into. Here is a map showing the prevalence and incidence of Parkinson's disease in Asian countries. So the prevalence of Parkinson's in Asia. As you can see, India has a prevalence of 30%. More than 10 million people worldwide are living with Parkinson's disease. Men are more likely to have Parkinson's disease than women. However, people diagnosed with Parkinson's disease increases with age regardless of sex. So now let's come to the next topic, which is dysphagia and Parkinson's disease. We can begin by discussing deficits noted in the oral phase of swallowing. These include drooling or dry mouth, difficulty manipulating food or liquid, repetitive pumping movements of the tongue, oral residue, premature spillage, and piecemeal deglutition. So the first one is, you can see, drooling. Because of the rigidity and the slow movement, there's difficulty in efficient mastication, as you can imagine. Because of tremors and repetitive movements, there's repetitive pumping movements of the tongue. Because of rigidity, again, there's decrease in clearance of oral food or pocketing of oral food in the mouth, which leads to presence of oral residue. And there can be premature spillage of food out of the oral cavity as well. Secondly, in the Parkinson's disease, in the pharyngeal phase of swallowing, the deficits seen include residue in the valleculi and piriform sinuses. So you'll see that during an instrumental study, there is food or bolus stuck in the valleculi or piriform sinuses. Because of the slow movement, again, there's delay in swallow trigger. Globus sensation, which means this feeling of food stuck in the food pipe or the esophagus or the pharynx. There's aspiration in almost 50% of dysphagic patients, something that is very important, a huge number. The incidence or prevalence of aspiration is very high. There are somatosensory deficits, and there's a reduced spontaneous swallow. Again, keeping in mind all the symptoms, bradykinesia, rigidity, slow movement, these lead to these signs or symptoms seen of dysphagia seen. And lastly, in the esophageal phase of swallowing, we may notice hypomotility, hypo meaning slow or less, so the transfer of food and the efficiency with which it moves from our oral cavity or to our stomach would be less. There's incomplete upper esophageal opening and abnormal LES opening of the sphincters. There are multiple contractions and there are spasms noticed as well. This slide looks at a number of consequences of dysphagia, which include malnutrition, dehydration, aspiration pneumonia. There's moreover compromised health, choking, and even death. Adults with dysphagia may also experience disinterest or less enjoyment of eating or drinking. which can lead to embarrassment or isolation in social situations involving eating. Dysphagia may increase caregiver burden and may require significant lifestyle alterations for the patient as well as the patient's family. So something to keep in mind. I really like this slide because when you look at it, you realize we are not only treating the signs or the symptoms, we are helping our patient. Dysphagia is a cycle of complications, and as a speech language pathologist, it is our role and responsibility to help our patients overcome this to the best of our abilities. Now our next slide focuses on a study which reports that overall Parkinson's patients are 3 times more likely to have swallowing disorders than healthy controls. It's a study done by Kaff et al. Due to significant differences between subjective and objective measures, it suggests that dysphagia is common in Parkinson's disease, but patients do not always report swallowing difficulties unless asked. One explanation for this is the lack of consistency in the definition and preferred assessment of oropharyngeal dysphagia in Parkinson's disease. Another explanation is the difference in disease severity. So let's say there's an individual with Parkinson's disease. He goes to the neurologist's office. The neurologist asks him that, do you have any difficulty with swallowing? And the patient says no. He's referred to a speech language pathologist. And we ask, do you have any difficulty with swallowing? And the patient says no again. We do a modified barium swallow study, which is an instrumental examination. Do we see any dysphagia? Yes, we do. This is because there's slow progression of dysphagia in Parkinson's disease. And don't always take the patient's word. Is a patient interview and their subjective opinion important? Of course, definitely. But they are unable to detect signs and symptoms of dysphagia, which is why in individuals with Parkinson's disease where there's a high risk of dysphagia, an instrumental study is indicated. I'm going to let you look at the slide for a minute just so we can reinforce the thought that individuals with Parkinson's disease are unable to detect signs and symptoms of aspiration or penetration. So, a swallowing study, an instrumental swallowing study is indicated. This is a study done by Kaff et al. And they completed a systematic literature in a review in February 2011. They compiled 12 studies which were suitable for calculating prevalence rates. 10 studies provided an estimate based on subjective outcome, which proved statistically heterogeneous with a pool prevalence estimate of 35%. So based on clinical or self-reported assessment, which means if I ask an individual with Parkinson's disease, do you have any difficulty swallowing? 35% of the patients said yes. 4 studies provided an estimate based on objective measures. So when an instrumental swallow study was done, the prevalence of oropharyngeal dysphagia increases to 82%. So think about it. It was only 35 out of 100 people with Parkinson's disease said they had dysphagia. And then when they did a modified barium swallow study, 82 out of 100 people showed any kinds of signs or symptoms. In other terms, subjective dysphagia occurs in 1/3 of community-dwelling Parkinson's disease patients, whereas objectively measured dysphagia, which is objectively measured by instrumental studies, the rates were much higher, with 4 out of 5 patients being affected. A large follow-up study was done of 252 patients with Parkinson's disease, and it confirmed aspiration risk, revealing that 10% of them developed pneumonia, which is aspiration pneumonia. Factors like sex, age, disease duration, and dementia all contribute to the presence of swallowing impairments. So this gets us to the question, what is aspiration pneumonia? Aspiration pneumonia is the leading cause of death in Parkinson's disease. It is the common result of dysphagia in individuals with Parkinson's disease. It is a type of lung infection that is due to relatively large amount of material from the stomach or mouth entering the lungs. So over a period of time, there has been aspiration. It could be silent. There could have been signs of symptoms of aspiration that have been occurring, and they're entering the stomach or the mouth. And these signs and symptoms all eventually lead to aspiration pneumonia. Signs and symptoms often include fever and cough of relatively rapid onset. So it's a lung infection that develops after you aspirate food or liquid into your lungs. It's a multifactorial event, which means just choking one time on food or saliva alone is insufficient to cause aspiration pneumonia. A patient can also aspirate food or liquid from their stomach that backs up into the esophagus. So the food can come up from the stomach after being swallowed and eaten, and can go into the lungs and cause pneumonia. Aspiration pneumonia develops in the setting of altered bacterial flora in the oropharynx, a reduced resistance of the host, and decreased pulmonary clearance. So three things: bacterial flora, reduced resistance of the host, and decreased pulmonary clearance. Cough reflects sensitivity and cough intensity. So am I coughing hard enough or loud enough? Am I able to clear my throat? All of that tends to deteriorate and advance Parkinson's disease and can lead to the presence of silent aspiration. So if the patient is aspirating and his cough abilities are less, he would not be able to cough up anything that goes in his throat. That goes towards his lungs. If a patient is unable to cough up the aspirated material, bacteria can grow in the lungs, and this reduced pulmonary clearance leads to an infection and the prevalence of pneumonia in individuals with Parkinson's disease. So what are the symptoms of aspiration pneumonia? They include fever, persistent coughing, which may or may not bring up mucus, sputum that is pink or frothy, and confusion or fatigue. A healthcare provider or a physician diagnoses aspiration pneumonia by conducting blood tests, a sputum test, a chest CT or X-ray, and a modified barium swallow study. All of these tests are required to diagnose aspiration pneumonia. Certain risk factors that may increase occurrence of aspiration pneumonia include age, prolonged hospitalization, reduced mental or functional status, poor oral hygiene, etc. I would like to mention that there was a nationwide study done in Taiwan by a group of authors focusing on aspiration pneumonia risks, and identification of risk highlighted chronic heart failure, chronic kidney disease, and oral hygiene as being associated with an increased risk of pneumonia. In particular, older female patients with Parkinson's disease with chronic heart failure and older male patients with Parkinson's disease with chronic kidney disease had a significantly high risk of pneumonia. Other factors include age, GERD, which is reflux, poor oral hygiene, a compromised immune system, damaged lung tissue due to smoking, COPD, vomiting, as well as severe spasm, which can allow food to go from the esophagus into the trachea. I would like to share this study done by Langmore, which was done to analyze risk factors related to aspiration pneumonia. They concluded that aspiration pneumonia is a multifactorial phenomenon, which we spoke about before, and no single predictor can cause this disease. A major conclusion was that dysphagia and aspiration are necessary, but not sufficient conditions for development of pneumonia. So for pneumonia to occur, dysphagia and aspiration are very important, but not enough. Predictive risk factors fall under 4 categories: medical health and health status, oral and dental status, functional status, and swallowing and feeding status. Major risk factors were dependency for feeding, which is a powerful indicator because it tends to increase the quantity of material aspirated. Have you ever had somebody feed you? They don't know the rate of your feeding. They don't know how much time you're taking to swallow, the quantity you're taking in your spoon. Because if someone is very dependent for help during feeding, the amount of aspiration and the risk of aspiration increases, as well as the quantity of food aspirated. It is also important for us to know that several studies of tube-fed patients who are taking no food or liquid by mouth have shown that tube feeding is associated with a higher risk of pneumonia than in patients who are eating. Again, something that was very surprising to learn that, okay, he's completely NPO, how is he getting pneumonia? Tube, a G tube or any kind of tube feeding, an NG tube, can lead to pneumonia in patients who are not eating from their mouth. Here are some statistics of aspiration pneumonia and Parkinson's disease. Parkinson's disease patients experience higher rates of hospital-based complications and often suffer substantial clinical deterioration while hospitalized. It has been estimated that Parkinson's patients have a 3.8 times increased risk of developing aspiration pneumonia when compared to the general population. Aspiration pneumonia has been reported as the most frequent cause of death in Parkinson's disease patients, and it has been estimated to account for 70% of mortality. I'm going to say this again. Aspiration pneumonia has estimated to account for 70% of mortality, which is a very big percentage. Another study done by Martinez and Ramirez et al. Reveals a frequency of in-hospital aspiration pneumonia of 2.4%. So to conclude, very high risk of aspiration pneumonia, and an instrumental study is indicated in individuals with Parkinson's disease, since they have a high risk of not subjectively recognizing any signs or symptoms of dysphagia. Our next section focuses on evaluation and treatment of dysphagia. A clinical...
Rabab, can you hear me?
Yes.
I think we are running out of time, so could you summarize what you have to say?
3 more slides and I'll be done.
Okay.
Yes. A clinical swallowing evaluation is done by a speech-language pathologist to evaluate and treat swallowing disorders in individuals with Parkinson's disease. A swallowing assessment allows the speech-language pathologist to integrate information from medical history, oral examination, and the instrumental evaluation, like we spoke about before. Patients with Parkinson's disease may be unaware of the presence of dysphagia and its signs and symptoms. On the outside, dysphagia may not appear to be present. However, as we discussed before, it is our duty as a speech-language pathologist to ask these questions specifically. Have they lost weight? Are they avoiding eating or drinking something? Do they see there is oral residue in their mouth? Once concluded, if there's a diagnosis of dysphagia, our treatment protocol will focus on decreasing the signs and symptoms. So always consider a swallowing evaluation to rule out dysphagia in individuals with Parkinson's disease. The treatment of dysphagia and Parkinson's disease is something that I'm not going to go into. Just remember, treat the deficit. Do not focus on traditional swallowing therapy because any kind of strength training is not indicated. Some options for treatment of dysphagia and Parkinson's disease include medical management, deep brain stimulation, EMST, NMES, the Lee Silverman voice treatment, as well as skill training. Here are some additional references that I would like to share with you. There are references that I've utilized many references to prepare this presentation, but these are some additional ones that provide great information. Most of them are available on YouTube. Before I go to the questions, just to summarize, if you take anything away from this presentation, one thing to take away is traditional swallowing therapy is not indicated because there is no weakness of oral structures in individuals with Parkinson's disease. So just something to remember, and I think I'm done. Happy to take any questions.
Could I have Professor Gayathri ma'am?
Yeah. Hello, can you hear me?
Yes, ma'am.
Okay. Thank you so much, Rabab. It was great having you, and very lucid presentation you have done on the aspects of dysphagia as well as on Parkinson's disease. So we are very, very happy to have you here with us. I know I was not there at the initial part, so I will just like to say, kind of discuss your, CV and just introduce you a little better than what we had earlier. To all our listeners who have, I'm sure, enjoyed this presentation, we have Rabab Rangwala with us today, who is a medical speech language pathologist. She has completed her undergraduate studies from Nair Hospital in 2016. And then she went on to complete her master's in Dallas. Then she did her MS in communication disorders. Her SLP, she is currently pursuing her PhD at Northwestern University in a lab focusing on dysphagia under the mentorship of Dr. Bonnie Martin Harris. And she's a practicing clinician working at an inpatient and outpatient facility. Rabab has had experience presenting on dysphagia and its implications on Parkinson's disease at local and national forums in the USA. She is also interested in voice therapy in the transgender population and is the lab manager at Dr. Sundarajan's lab at San Francisco State University, and is currently a first author on a manuscript which is still in progress. She was also a research assistant at the Parkinson's Voice Project, where she got trained in the Speak Out therapy and has the opportunity to interact and learn more from individuals with Parkinson's disease. She is a strong advocate of EBP and has launched the Made in India SLP podcast, which I'm sure many of you all may have already benefited from. Her interests lie in adult medical speech language pathology, focusing on swallowing, speech and language therapy. So, Rabab, you have been, really doing well in your clinical and in your research abilities. And I'm sure now we can go to the questions which our listeners have. Some of the questions that are there are in terms of, there is one question which was on with how to differentiate between pneumonia and PNA by Sanjay Kumar. Could you answer that?
Yes, ma'am. First of all, thank you for the introduction. It's an honor to be introduced by you. I did study under Gayathri ma'am at Nair, and it was an enriching experience. Keeping pneumonia and aspiration pneumonia and their differentiation in mind, aspiration pneumonia is caused by aspiration of food into the lungs. Pneumonia can be caused by viral infections or bacterial infections. It has more of an its etiology is more infection based, whereas aspiration pneumonia's etiology is more dysphagia based, where food is aspirated or penetrated into the lungs and leads to development of an infection. Hopefully that answers the question.
Okay. There is one more question in terms of how do you handle xerostomia management in persons with Parkinson's disease, by Arya. Okay.
Xerostomia, for individuals who do not know, is caused due to a very dry mouth. It is something that I've usually seen a lot in individuals with head and neck cancers. And one of the most important causes of xerostomia is radiation therapy. But any kind of treatment of radiation of xerostomia focuses on keeping your mouth wet if you don't make enough saliva. Doctors that I have seen do prescribe some kind of gel or ointment to keep on applying in your mouth to help with that dryness. And something else, it also focuses on diet modification. So you're drinking a lot of liquids, focusing on hydration to keep your mouth as wet as possible.
Okay. Okay. Thank you so much, Zaina. Rabab. One more question is on objective testing. Like, do you need objective testing to convince and support your findings with the patient and the family, especially when they are adamant to continue on certain diets? This is by Mr. Sanjay Kumar.
Yes. So something that we've noticed and something that I think is a daily struggle for very many speech language pathologists is convincing and advocating for our patients to get diet modifications. Does anybody want to have pureed food? Probably not. Anybody wants to have thick liquids? No. But if you do an instrumental study, you have objective analysis to show your patients. Something that I do is, as a start of therapy, I pull up a YouTube video like the one I showed of an abnormal swallow and show them how food is going down the wrong way into their lungs. Using very simple terms like your food tube, your windpipe, food's going into your lungs, it can cause pneumonia, which can lead to fever and hospitalization. If you have done an instrumental study, it complements your subjective evaluation very well, because then the patient is seeing his own report instead of a random person on YouTube. So show him the report, show him what he ate, show him what, you can always show him, okay, I gave you a piece of biscuit. Look at this, where the biscuit's going, which is why you feel that cough or why you feel something stuck in your throat. I do keep in mind that if I was a patient, I would like my doctor to tell me why a specific remedy is being provided. If he's like, okay, you need to have bed rest for 20 days, and I can't afford to bed rest for 20 days, I am going to ask questions. If you want your patient to follow diet modifications and eat a thick liquid or a pureed diet for a certain amount of time, you do have to justify and show him the analysis behind your evaluations.
Okay, Rabab, now, yeah, especially in many contexts in India, we do not have, support of objective tests. In such a case, what would we do, when they are adamant on continuing on certain diets?
Yes, ma'am. That thing that we keep in mind. First thing, of course, advocate for an instrumental evaluation. If they can travel somewhere and get it, that would be great. If not, try to use your clinical swallow examination to the best of your abilities. So you can focus on oxygen saturation levels. It is a procedure that you have to use with some kind of precaution, but showing that oxygen level go down consistently during any kind of solid food intake you can show them that it might be going into their lungs. Try to have a protocol for your clinical swallow examination and try to use the information you get from them. He's like, okay, I'm coughing all the time when I'm eating. So that's something that you can use to explain to them. And the good part is now that we have cell phones everywhere. So you can use a video to explain to them and show them how the X-ray works so that they can have better information.
Okay, thank you. Prachi Agarwal is asking as to what do you mean by transitional food? In the diet chart, I think that was meant, no? So what is transitional food?
Yes, so the team comes up with dividing its solid food into levels, I believe 3 to 7. If I'm looking at transitional foods, it means foods that are changed or diet modified. That is a very good question. I've never looked at that part of the ITSE framework, but if I am to understand, I think it's any kind of food like minced and moist or mechanical soft, so it's yet solid, but it's transition between regular solids versus pureed, which comes between solids and liquids.
Okay. Now, there is one more question from Sarvangi Shah, who says, unless the patient admits any difficulty in swallowing, how can we help them in case of persons with Parkinson's disease? This was my question also, in terms of when do we really start talking about dysphagia in these individuals, when we know it is going to happen, but it has not yet started happening. So when would you initiate, this discussion with the person involved as well as his caregivers?
Yes, ma'am. That is a great question. That's where a relationship with other medical professional comes into play. The diagnosis of Parkinson's disease is made by a neurologist. It is our duty as a speech language pathologist to educate and make our neurologists around us aware of the impact of dysphagia and Parkinson's disease. Something that I did when I was working in my outpatient rehab is take studies, because I feel like that is the best proof. Okay, there's this study done, that study done. It's showing the prevalence and incidence of aspiration pneumonia in Parkinson's disease. So you're increasing the chances of a referral. If you see any patient with Parkinson's disease, always do a baseline swallow examination. Chances are that they are one of the patients who show dysphagia signs or symptoms towards the end of the progression of the disease, but it is our due diligence to do a baseline swallow examination. If you do not...
Okay, continue.
If you do not see any signs or symptoms, what do? There's nothing you can really do. I cannot give them oromotor or strength training examination strategies or techniques because we know that's not indicated. So the only thing I would do is educate and counsel. Tell them that, these are the signs or symptoms you would see. There would be difficulty chewing, difficulty swallowing, coughing, change in voice. If you see any of these, please come back and have a swallowing evaluation.
Okay. Acha, Rabab, you're having compliments that your presentation has been excellent and very interesting, but your viewers also would like to see you. So could you switch on your webcam?
I would. We tried 20 minutes before this to try to figure out why my webcam was not working. So I'm so sorry.
Okay, okay. It's not working, is it? Okay.
It's not working with the app for some reason.
Okay. There is one more question from Mitali Sharma. The PEG or nasogastric tube, which has a higher prevalence of aspiration pneumonia. She has not specified it for Parkinson's, but you can consider it either in all cases of dysphagia or with those with Parkinson's.
So the PEG tube is something that goes through your stomach. The nasogastric tube goes through your nose. The aspiration prevalence, as per my knowledge, on both, it cannot be differentiated based on the type of mechanism used, because when aspiration occurs that time, it means the contents from the stomach are coming up and going into the lungs. So it's like reflux. So it doesn't really matter which tube is used, because eventually both the tubes send food to the stomach. Any kind of the protein powder or the protein shake that they use goes to the stomach, and then the food from the stomach comes up to the lungs. But again, I may be wrong. That's something that I've not really looked into.
Okay. Do we have Srushti Shabnam asks whether we have any particular exercise to reduce rigidity neck region in persons with Parkinson's disease?
Yes. So this is more in the realm of physical therapists, occupational therapists. I do know that they work on neck stiffness, neck pain, and neck rigidity in Parkinson's disease. It is not something that is in our scope of practice, but in my voice therapy with patients with Parkinson's disease, we do simple neck exercises, very easy. We are not trained in the perfect physiology of the neck and how exercises can positively or negatively impact. So I'm always cautious and just give simple exercises that just
then
improve.
in that case should we also be in touch with the physiotherapist then, to along with the physiotherapist, to work with them, especially in these kind of problems?
Yes, ma'am, because the physical therapists are play an important role in the interdisciplinary team, and the prevalence and the possibility of falls is very high in individuals with Parkinson's. So a physical therapist should be a part of the team at all times.
Okay. Srushti is also asking that many persons with Parkinson's disease have complaint of constipation. Do we suggest any particular diet modification to reduce that?
So again, I do not think it's enough scope of practice. That is more of a physician or a dietitian, because we do not want to. Of course, we can tell them that drink more water, eat food that's soft. But if I try to stay away from giving any recommendations, because we do not want to provide any medical recommendations. Refer them back to their doctor for that. I did add in the notes, I worked for the Parkinson Voice Project, and they have a bunch of free lecture series online that focus on addressing all these simple or addressing all these subjective problems that individuals with Parkinson's disease get. So like constipation, dry mouth, frequent falling. So they have people from other teams talk about it. So it would be a nice resource for the patient as well.
Okay, I could just add one aspect here. See, a very simple remedy like, jeera, everyone knows, na, jeera. If you just say add half a teaspoon of jeera in say 4 cups of water, and then you reduce it to 2 cups. Okay, and that if the person is having, very often it helps. A simple remedy like this, or asafoetida in a little bit of chas or buttermilk, that helps in working with in reducing constipation. So it's a very simple home remedy and has no side effects, so that can be tried. Now, this is a very topical question, Rabab. In this situation of corona, according to you, which is the best and safest way for assessment, and which is the one that you are using? This question is by Apurva Nikam.
Yes, something that I'm following working in the US is the American Speech and Hearing Guidelines, because any kind of swallowing therapy or evaluation is an aerosol generating procedure, which puts us at harm of the droplets getting spread in the room we are working in. So like eliciting a cough during an oral motor examination can lead to a lot of the coronavirus getting spread in the room that we are. So of course, we cannot put a hold on swallowing evaluations forever till this goes away. So use adequate precaution, use your PPE kits. Something I have been doing is not eliciting a cough unless I really need it to be elicited, just to not cause so much virus to be spread in the room. and just doing the CSE as I would. Our protocol for evaluation of therapy does not change because there's a virus, but at the same time, we do need to just be cautious and keep ourselves and our patients safe using PPE or any recommended guidelines.
Okay. So you do see swallowing patients, but if not indicated, only cough is not elicited. Other than that, you do your clinical evaluation, right?
Yes, ma'am. Before I started my PhD, we were seeing patients in the inpatient facility just as we used to before, just making sure that I'm wearing a mask and a shield at all times. Because of the asymptomatic nature of the virus, we need to be careful about, we need to keep in mind that any patient can have the virus, so to wear it at all times.
Okay. Preeti Shetty asks that in Parkinson's disease, there are evidence of going off vocal folds. So what would be the intervention strategies for them? And what intervention strategies for dysphagia?
Yes, so for the vocal folds, there's a hypokinetic dysarthria that usually occurs. There have been studies about how they think that the pharyngeal muscles play a part in the rigidity process of Parkinson's disease as well. So that would be a nice resource to look into. The Speak Out therapy program is something that I am trained in by the Parkinson Voice Project. It focuses on increasing vocal intensity of the patient with hypokinetic dysarthria to increase speech intelligibility. So focusing on any increase in intensity during speech therapy is definitely an important part of our rehab process for voice. And in the presentation, we spoke about rehabilitation of dysphagia and Parkinson's disease. It would focus on, it depends on what your patient is presenting it. So I'm focusing on treating the deficit. If there is, let's say, oral pumping of the tongue, I would work on a diet modification that helps decrease the risk of aspiration or penetration. So just like that, deficit, and remember that strength training is not indicated.
Okay, I think we are running out of time now. In fact, I also wanted to know about the Speak Out. So it has some similarities with the Lee Silverman technique also, right? Because that also
Yes.
The focus is for the individual to speak out loudly, and that is I think maybe their strategies, there are some similarities between them, right?
Yes, ma'am. So the Speak Out focuses on speaking with intent, while the Lee Silverman technique focuses on big voice or loud voice. Based on psychological phenomena, they differ, but their overall perspective of increase in loudness is the same.
Okay.
Actually, we are very happy to have Rabab.
Yeah.
Ma'am, she has agreed to take one more lecture for us, specifically communication in PD. So maybe somewhere in the end of the year, as per her convenience, we would be able to get her expertise, and that would be really sweet of her to enlighten more.
That will be great. That will be nice. So I think, Rabab, we really learned a lot from you today, and you made it very lucid and interesting for all of us. Plus, you gave us a lot of references also. We really appreciate that. And I think as SLPs, we also are getting more and more into like how dysphagia, not just neurogenic dysphagia, but now we are also looking into specific populations and seeing how a clinical profile of dysphagia changes from, say, a person with stroke to a person with ALS to a person with Parkinson's disease. And today we've had the pleasure of listening to her, and we've got so many details in terms of the clinical profiles in a person with Parkinson's disease when he has dysphagia. And also, I think you focused a lot on the aspiration pneumonia part, and I think that really will go a long way for all of us to be, really watchful for these signs and symptoms. And, because that is the nightmare for any SLP working with swallowing, that the patient should not have aspiration pneumonia. So I think it was very holistic, and we really thank, Rabab for all the presentation and the way you handle the questions. Really thank the organizers for a wonderful session and the way it was planned, very smooth presentation. Only I had a little problem tuning in, but it was a very well organized session. So my thanks to ISHA, Thanks to the organizers and the panel and all of you all, and the audience especially for being there with us. Sonal, would you like to say anything, or Dr. Krishna, would you like to say something?
Hello, am I audible now?
Yes,
Yes, ma'am.
Yeah. Yes. I have a great privilege to really have this enlightening, wonderful speaker of Made in India SLP, and I'm really thankful to her for taking up this great podcast and enlightening the Indian SLPs and students. So I thank Rabab for such a wonderful session. You made it very easy, crisp, and very simple slides, lucid way. Step by step you took the students and professionals to understand the swallowing and then the PD. So that was great presentation. And Gayathri ma'am, thank you so much for a great moderation and great comments. I know from the beginning the audio and technical glitches I also faced the same, but it's okay. We have a successful webinar. It got connected well by you. So I thank you for, in short time we had you as a moderator, and your great comments were really helpful. I'm sure our audience today, there are 61 still there, so I'm glad for that they have got a take-home message that I will take it ahead, that how do they help person with Parkinson's disease and other degenerative disorders also. So thank you so much all. Thank you so much audience. Keep in touch. We have Rabab's consent for this video to be posted for ISHA. So I'm sure it will be helpful for the audience as well. Thank you, Rabab. I thank Dr. Krishna sir for always being very helpful, very supportive, and he's a president of ISHA. He had been supporting Med SLP series for safe swallowing, cognition, and communication. It will be coming ahead. And I ask all the audience to stay tuned and encourage your students to be life member of ISHA, and all the PG students to always attend this ISHA webinar series. Do give input, do volunteer if you have something to share with us. I thank Sunil, Joint Secretary of ISHA, and Dr. Indranil, Secretary of ISHA, and all the ISHA team. A special thanks to Amulya for always helping us with technical support and all time being on time with the coordination team. Thank you so much.
Thank you so much, ma'am. Thank you.
Yeah, thank you,
ma'am.